Hello and welcome to another episode of the Massage Matters podcast with me, Matt Scarsbrook, Anna Maria Mazzieri and Becky DeMott Horton. Together we are the Massage Collective and we are attempting to bridge the gap between evidence-informed practice and traditional hands-on manual therapies. Today, we're taking a slightly different tact. We are hosting Jack March, who is also known as Rheumatology.physio, if you want to look him up on the internet, which I highly suggest that you do. Jack is a physio and he specializes in rheumatology, which is a range of conditions that we are likely to come across in the clinic reasonably regularly, and it's up to us to either be able to identify the red flags associated with it and refer on, or to be able to support that client in their treatment in the best way possible. And being that we are by no means experts when it comes to this, we thought we'd go to the expert. No pressure, Jack. So, without further ado, Jack, welcome. Thank you for coming and joining us today. Would you mind doing the classic and introducing yourself and give us perhaps a little bit of background about why rheumatology?
Yeah, no worries. Thanks for having me. It was a very lovely intro thing. I don't know if I'm the expert with a capital T, but I like to portray myself as such.
Within this metaphorical room, you are the expert.
Excellent. Like you say, my name's Jack and I have specialized in rheumatology since about 2011. And mostly, why rheumatology? Mostly because I find it fascinating and it's just about the only thing in therapy I've found that I'm any good at. It was a sort of a path of least resistance situation. And then over time, I've been lucky enough to be asked to speak at various events, and people seem to enjoy that. So I moved into teaching as well, which is probably the main role that I do now, is educating therapists, mostly physiotherapists, admittedly, and I do lean into advanced practice more than anything else, just because that seems to be where the interest is at the moment with first contact practitioners and stuff. But certainly it's something that has grown over the last few years. And like you say, my website and my courses have done reasonably well. And then the rest of the time I spend doing podcasting, so I'm behind the microphone today being asked questions, which is nice, but I also sit the other side asking plenty of questions for Physio Matters podcast. I have my own podcast, Rheumatology.physio podcast, and various other things, and then creating the therapy live events as well with Physio Matters and Choose Media, so that's great fun. And then clinically I do some second opinion work with regards to patients. So your typical patient that would come and see me has seen maybe a physio in private practice and they are wondering whether they have an underlying rheumatology condition. They send them to me and I provide my opinion on such, is usually what I get up to. So I have quite a varied role. It's very interesting, and get to work with you guys, which is always fun.
I'm not sure fun's the right word, Jack. I think we've managed to age even you over the last year.
So for anyone who's not yet aware, obviously Massage Matters is part of the larger Physio Matters network, and it does mean that behind the scenes Jack is actually a producer. How do we phrase you? So Jack is instrumental in making sure that we get our episodes out to you guys on time, because if it was left to the three of us, it would be rather hit and miss, I suspect. So okay, so let's start then. So we're not going to labour the point around red flags and things too much today. We want to really get into the meat of what is it that us as soft tissue therapists and manual therapists can do to support clients. But for anyone who is unfamiliar with rheumatology, and I'll throw myself into that bucket quite happily, can you start off by giving us a little bit of a definition, and then we'll go in and we'll touch on those red flags just so people sort of get a refresher.
Yeah, so rheumatology is a really broad specialty. The British Society of Rheumatology reckon there's well over 200 disorders that would come under the specialism of rheumatology, and they vary from the very common, like osteoarthritis, osteoporosis, to the very rare odd types of muscle inflammation and lung inflammation that has only been seen in the UK maybe once or twice ever. So there's some stuff that certainly us as physiotherapists, massage therapy, people who see mostly musculoskeletal conditions, we just don't need to worry about. They either are so rare we will never see them, or they aren't coming to our clinics, so we don't need to worry about them too much. But the sort of classic type of thing that people would think of under rheumatology would be rheumatoid arthritis or ankylosing spondylitis. Lupus is another one that people are usually well aware of. And these conditions usually, I say usually, they're not always, but usually are autoimmune in nature, which means that the problems are caused by your own immune system. So other examples of that would be type 1 diabetes, multiple sclerosis, for example. So what basically happens is there's a fault, for want of a better term, in your immune system, and it, instead of only reacting against things that aren't you, so viruses, splinters if they get into your skin, bacteria, etc. Instead of reacting only against those, they start reacting against your body's own tissues, and then that's what causes the problems moving from there. So they're really fascinating, and what I find interesting is you can never learn enough. So as soon as, like an onion, as soon as you peel away one layer of, you think, oh, I understand that, then you realize actually it's infinitely complex underneath that layer, and then your brain falls out of your ears. So that's really fun. And it's become sort of my niche that I live in, and people seem to come to me for questions and things like that. So there's a bit of an ego boost with it as well for me. I think it's quite fun to be that guy. But it's one of those things where the conditions themselves are relatively rare. So ignoring osteoporosis and osteoarthritis for a minute, they are relatively rare. So if you look at rheumatoid arthritis, you're looking about maybe just over 1% of the population will be diagnosed with rheumatoid arthritis over their lifetime. But if you combine all of them together, all of the conditions added together, you're looking maybe around 3 or 4% of the whole population at any one time is diagnosed with a rheumatology condition. So as you said, they are going to come into our clinics. We are going to see them, and really there is a big distinction between those that are undiagnosed and those that are diagnosed.
Jack, is fibromyalgia under rheumatology?
Fibromyalgia gets under rheumatology a lot because of its nature. So widespread pain, multiple joint pains, other associated symptoms like fatigue, etc. But it isn't a rheumatology condition because it's, as far as we can work out, it's not inflammatory in nature, so it's not related to the immune system. As far as I can work out from the latest research, it might be neurological is the wrong word. It might be related to the nerve tissues, but I've moved away from trying to understand it to a degree because it's, like I say, it's not inflammatory.
Yes, it's multifactorial. Yeah. I usually get diagnosed by a rheumatology consultant, isn't it?
It often is, again, because they often get referred into rheumatology. In all honesty, I don't think fibromyalgia patients, outside of a few specific reasons, need to be under rheumatology at all. It can be managed in primary care under the GP and diagnosed under the GP. But some patients obviously need rheumatology conditions ruling out. So then that would be appropriate for the rheumatologist.
So I'm interested, Jack, in that you make that distinction between there's quite a difference from somebody who is diagnosed and being managed with their rheumatological condition to an undiagnosed person. How, you might not know this, but how long does it often take for somebody to reach that diagnosis? Is it common for somebody to go on for a while with a rheumatological condition without a diagnosis?
Yeah, it does vary between the conditions. So rheumatoid arthritis, for example, is pretty well recognized now. The delay to diagnosis with that is not so high, mostly because of a lot of work around working with GPs and physios and things, and other healthcare professionals to get the signs and symptoms out so they're recognized. And also, I think patients as well are more aware of rheumatoid arthritis. and the familial links, so genetic links, are more obvious in rheumatoid arthritis. So a lot more likely to have your mum is more likely to have had rheumatoid arthritis. So you already know when your fingers swell up that might be what it is. So that's not so much. But then when you look at more complex conditions like the inflammatory spinal problems like ankylosing spondylitis is one type, then we do get big delays to diagnosis. So in men, for example, it's approximately 6.5 years, and women 8.5 years. That's the average.
Wow.
So that's a big problem, and that's not improved over the last 10, 15, 20 years either. That's still the same as it was 20 years ago. We're not getting better, which is rubbish. Lupus is another big problem. That anywhere between 2 to 20 years, depending on where you look, for lupus as well. But again, because of its complexity, and it's a difficult thing to diagnose. So yeah, there are some big delays to diagnosis. And in all honesty, I think the audience that we're speaking to with massage therapists, I don't want people to feel like it's their responsibility to be picking these patients up.
Yeah.
Like I said at the beginning, I speak to a lot of advanced practice, so first contact physios, extended scope physios, etc. And these are complex they're not musculoskeletal diseases, they masquerade as musculoskeletal diseases. So it's something that I think massage therapists need to be aware of some signs and symptoms, but they shouldn't feel like it's definitely their responsibility to be assessing people for these in depth. But if someone turns up with some specific stuff, then they need to recognize that. Really.
No, yes, certainly. But it's really, really important that because they come to us, when people have pain, usually we are the first port of call. And that's where we can pick up those signs, the clinical picture that might make us think, do you know what? This client is not improving. There are few of those signs that might indicate let's refer. And I think sometimes it's at our level that they're not referred quick enough. And that's where the problem is. But I agree with you. I agree to the fact that it's not really our responsibility, but we need to keep our threshold of referral rather low, so that we allow them to eliminate, we allow the GP or else to eliminate an inflammatory source of the pain.
Yeah, for sure. And there is, if you look at we're going to get into real weeds here, but in some of those people in the inflammatory back area, they see on average around 8 clinicians before they're diagnosed.
Wow.
Well, so this is what I mean about I don't want massage therapists to think that they're part of the problem, because everybody is the part of the problem. It is including extended scope physio, spinal assessment clinics, those people that are supposed to be highly specialist are still missing.
If people will work more multidisciplinary, I bet this was not going to happen. If we would be able to have a good open pathway of multidisciplinary communicating system, I bet that those years will be reduced. Those years before before diagnosis will be reduced.
Oh, sorry, Becky. I'm going to jump in very, very quickly. I've got a couple of questions that I don't want to let slip until they're totally irrelevant, although we might already be there, because we've started to dive into some really interesting detail. But just for clarity then, do all autoimmune diseases come under the heading of rheumatology?
No.
Are all rheumatological diseases autoimmune?
No.
Okay. No, it's really, this is useful definitions for me.
The problem is what we're doing, and I say this a lot, and I want to just put this out here right now. So the problem is when you look at an individual, they're an individual, right? When you talk about medicine, what we're trying to do is we lump a lot of individuals into groups, right? Because it enables us to be better for treatment and research, right? But the problem is each human is completely unique. So if, let's say, all 4 of us developed rheumatoid arthritis, not one of us would have the same symptoms, the same same sort of process of developing symptoms and so on. We'd all get it at different ages. We'd all get different joints affected, etc., etc. So the problem is if you go, is everything autoimmune? Then you go, well, actually, you name a condition or a medical problem in the whole sphere of medicine that does not involve the immune system. There aren't any, right? So the problem is I say no, that's incorrect, but that's because I'm trying to go, from our understanding of an autoimmune condition, where are we putting that on that as a definition? So like I said, osteoporosis, for example, is not an autoimmune condition, but bone turnover is related to inflammation. So technically, there are some autoimmune issues with it. So it's too complex to
well,
really.
There's also obviously a distinction between inflammation and autoimmune.
Correct.
Inflammation. So, okay. So then the other one, which I think is probably more relevant to us as certainly in the soft tissue therapy area where you're looking at rehabilitation as well. So I actually didn't realize that OA, so osteoarthritis, comes under rheumatology. In my head, OA is distinctly separate from RA, rheumatoid arthritis, and can be treated quite differently. And I think one of the things we're going to come on to a little bit later is sort of posing you the question, when we're working with someone with rheumatology conditions, are we helping them manage, or are we actually helping them rehab? Are they getting better, or are we trying to remain at least not getting worse? And so for me, it's really interesting that you actually put OA in and under rheumatology, because I would treat OA as, if someone came in diagnosed with OA, I'd treat that as, right, I can actually help there through my rehabilitation side of things to at least prevent it from getting worse, or at least that's what we're targeting. So I just wanted to make that point early on, and I want to come back to that then. So, Becky, sorry, you were going to jump in with something.
No, I was going to say, so I'm really glad you said that, Jack, about it's not massage therapists' responsibility to, or the fault isn't necessarily with massage therapists, and we can't be expected to pick these really complex conditions out, because I think that's really important to say to therapists. But what we do, and speaking to Anna's point, have a real responsibility to do is to know when something is outside our scope of practice and actually when we need to refer someone. So do you want to just, as Matt said, we don't want to labour it too much, but very briefly, if you put yourself in the shoes of a soft tissue therapist, if somebody walked in your door, what would ring alarm bells for you that you'd want them to go and see their GP?
Yeah, I'm going to caveat with this I teach for an entire day on this subject. So
yeah,
this
I get
really
that.
So the things that I think people really need to really be aware of is what inflammation looks like. So it always surprises me to a degree when I ask this question that people are unaware of what inflammation looks like, because I would challenge most people to have never been injured. At least they will have hurt themselves, and the same process occurs. So if you think about what would happen if you sprained your ankle, it would probably get swollen up, it would probably be red, it would probably be painful, and it would probably be quite hot, right? So if you see someone whose joint looks like that, or anywhere really, because you can get it in the soft tissues as well, if that's what it looks like, then you need to be wondering why that happened. So if there's a clear mechanism of onset, so they sprained their ankle because they rolled over on it, fine. And that was a few days ago, absolutely fine. If they go, oh no, it just happened and I can't think of anything that did that, that's when you need to go, okay, that's twigged something in my mind. So that would be the first thing. Then the second thing would be to do with spines, really. So spines don't swell, go red or hot or anything like that. So what you're looking at is, okay, what symptoms of this is this person coming in with? Much like I'm sure that you would say if someone's got real raging leg pain associated with their back pain, or pins and needles, numbness, that kind of thing. So it's a little bit more difficult with these conditions, which is why they get missed a lot. But we're looking for symptoms that are much worse in the early morning. So people waking up and their symptoms being worse for at least 30 minutes in the morning. associated spinal stiffness. So if they're reporting that they're very, very stiff in their spine with a reduced range of motion, that's another indicator. A significant improvement with anti-inflammatories is another one. A better with activity and not improved by rest. So hopefully the listeners will appreciate that that's the opposite to what you would normally see with injuries. Let's say to go back to my sprained ankle analogy, it would be very rare to sprain your ankle and then it'd be better walking around and not better when you raise it up on the sofa. Like this just doesn't happen. And also waking in the night with the pain, with the specific symptoms that they're getting. So those things can give you quite a good indicator with regards to spines. And then, like I say, we could and I do talk all day about it. So yeah, there's quite a lot more nuance to that. But again, it's like we said, it's hard to say where do massage therapists role in that, because I would say to people, if you don't know the nuance of how it's presenting, then you're going to miss quite a lot of them. But then massage therapists aren't working in spinal assessment clinics in this advanced role, so that's not their job. It's I think it was Anna said, it's outside of your scope. But those more barn door cases, I think, is where we can make a big difference.
And do you want to just touch on why it is so important that people get an early diagnosis with rheumatological conditions?
Yeah, so delay to diagnosis in the rheumatology conditions is basically linked to a worse outcome in pretty much any measure you can think of. So you name a measure, it's worse if you wait for the diagnosis. So pain levels, medication use, imaging, work status, depression, obesity, activity, you name it, it's worse. So it is very important. I think the thing to remember, especially for this audience, is that if people's symptoms are more subtle, so you're more likely to miss them for obvious reasons, that indicates that their disease is likely not to be so severe. So like I say, it's those really obvious ones, that's not the right word, is it? But the really ones which have a lot of swelling, a lot of redness, a lot of heat, that kind of thing, they are going to have worse disease, so they definitely need to be treated earlier. Whereas the more subtle ones, I hesitate to say you can get away with it, but it that is the truth, really, is they're more likely to have a less severe disease.
And then is that improvement in outcome with early diagnosis, I assume that's down to the efficacy of treatments that we have now for these conditions? And do you want to just talk about that as well? Because I know a lot of people, sometimes they can be quite aggressive treatments. So if we sometimes have a client that's come to us with a diagnosis and they're worried about the treatment, it would be kind of nice for massage therapists to maybe know a bit about just how effective that can be.
Yeah, so we're looking these days, take rheumatoid arthritis as the example. You're looking at getting about a third of patients into remission now. It's technically not a curable disease, but sustained remission is possible. And that is, like you say, they really hit them hard with medications. And it's a difficult thing when you first get diagnosed, really, because a lot of the medications are scary. So some of them are have been used in the past to treat cancer, for example, and you get a lot of steroids. The doses are very high, but the idea is to, as I said, get the inflammation down as quickly as possible, because that makes it more likely to go into remission. So you really hit it with everything to try and bring it down. It's far easier once it's down to keep it down. So medication, really, it's easiest to say every patient is going to require quite significant medications, at least in the beginning. It's probably a slightly I'd go 99.8% are going to need that. There is always the outlier in medicine that doesn't, but it's, there's no way any of us, me particularly as well, would say that to anybody that they're not going to need medication. It might well happen, but it's so rare that it's difficult to say that. So medication is absolutely vital, and it's one of those things where the benefits do outweigh the potential side effects. And what I often say to patients is that the side effects in the short term they might not be very nice, but actually we're looking at managing the symptoms so that their function is retained for 20, 30, 40, 50 years. These patients that are coming with rheumatoid arthritis and ankylosing spondylitis, they're young. It's young people's disease. They're in their 20s, their 30s. We're hoping they're going to live to 90 plus, etc. And, they're going to have to live with it for a very long time. So you want to get those symptoms right down, really. And then other things are pretty effective. So exercise is pretty good. Generally being healthy is pretty good. All those sorts of things, that normal stuff that we would give to any client. Not smoking particularly is very good.
Jack, am I right to think that within musculoskeletal, am I right to think that quicker we keep the inflammation down and less damage to the joint, especially a spinal level with spondyloarthritis, I can never get the name, okay. Yes.
SPA, yeah.
Exactly.
She was waiting for you to jump in and correct her, and you were not.
Yes, I was.
I'm gonna let you flounder. Yeah.
Yeah. Okay. That's it. Now you stop me completely. So, am I right to think that quicker we get the inflammation down and less damage to the joint, especially spinal level, is going to happen?
Yes, essentially, yeah. I mean, some people, regardless of what you do to them, they will go on to develop those changes, those joint changes. And other people, if you just leave them regardless, they won't develop those. Like I said, everybody's individual. Okay. It does vary. But yeah, you in general, you would say, yeah, get the inflammation down and you're much less likely to get structural changes.
Okay. So it's probably a good point then to move on to what we really wanted to get stuck into today, which is, so let's assume that let's assume for simplicity that our client has now been diagnosed with a rheumatological condition. And I mean, you can choose, I suppose, to lead us through where they might be at any point within their treatment. So it'd be useful to understand what's going to happen in those really early weeks when they're starting to be provided, as you say, quite high levels of medication. And then particularly when someone is given how high proportion you say are moving into remission, or at least getting that kind of level. That'd be really interesting. So what we really want to pick your brains on is, as massage therapists, as soft tissue therapists, is what can we be doing to support that client throughout their journey? What are they likely to be experiencing, so that we can kind of be prepared to help them and explain perhaps what's going on during a flare up, etc.
That's a difficult question, actually. So let's make it simple to begin with. So let's say the patient has no symptoms, and they're coming with some other issue. So let's say they've got rheumatoid arthritis. They're coming because they've lifted something up and their back hurts. You don't need to treat that patient any differently to you would someone without rheumatoid arthritis. You do whatever you would normally do. So there's that. Then if you take a patient who is who's on treatment but still retains some symptoms, then again, I would, depending on what their symptoms are, I would treat them as you would any other patient who presents with similar symptoms. So let's take our ankle sprain analogy, for example. If you had a patient in your clinic with an ankle sprain and it was a bit red, a bit hot, a bit swollen, and you were to do whatever treatment it is you deem appropriate to do, that treatment is equally appropriate with the rheumatoid arthritic ankle that would look pretty much the same if you just took a photo of it, for example. You do the same sort of thing. So if you think that would help with an ankle sprain, you would think equally it's likely to help with that rheumatoid arthritic ankle. No positives, negatives that I can particularly suggest. I couldn't sit here and say, if you've got a swollen rheumatoid arthritic joint and you apply massage to it, there are no overt benefits or negatives to that on a general scale. I'm going to real sit on the fence here. Much the same as you would with that ankle sprain. Sometimes you would do your treatment and that patient would get better. Sometimes you would do that treatment, they might be a little bit worse for a while and then return to where they were before. That's going to be the same with that rheumatoid arthritic joint.
Jack, sorry, can I go back a little bit from that?
Mm-hmm.
How do rheumatological conditions impact usually the person's daily life in a musculoskeletal perspective? So why those people will come to us? What might they be feeling? How is the function affected? The pain affected?
Yeah, so usually it's pain that people will be concerned about. That's usually why people attend therapists. But sometimes it's a reduced range of motion through stiffness and swelling, or reduced strength because they've not been able to use their joints appropriately for a while, or reduced fitness. Pretty much the same as you would get anybody else attending clinic, really. They just tend to present with slightly different sets of symptoms. So like I said, they tend to be worse in the mornings, tend to be better with activity and worse with rest, that kind of thing. So usually you would, again, if you take my ankle example, they'd probably be attending with roughly the same issues as you would with the sprained ankle. The difference is going to be the longevity of it and the fact that there was no mechanism of onset, really. So it's probably swollen, it's probably stiff, it's probably painful. And they want it to be less painful, stiff, and want to be able to use it better. So this is why I go to this, treat them roughly how you would treat so take the symptoms as they are and treat those as you deem appropriate, rather than thinking about necessarily the underlying mechanism, because really, if you go onto a biochemical level, they're fairly different. Unless you go really deep, and I can talk to that if you wish, but it's probably well outside of the scope of today. But what I often say to people on my courses is, from a clinical point of view, there's barely any difference. So they look red, they look hot, they look swollen, they're painful, much the same as any other injured joint would look like. So treat them as such. The thing with rheumatoid arthritic joints is that, with an ankle sprain, it's going to get better regardless. People don't have ankle sprains for 5 years. Now they get associated problems, but you don't have that initial swelling, pain, redness but rheumatoid arthritic will or can. So there's a longevity difference. And I think that certainly with soft tissue therapists and massage therapists, you have to be honest with the patient and you have to be honest with yourself that if after, I'd say one, but give it 2 treatments, if it's not making any difference, it isn't going to. It's not like, let's leave it 3 weeks and come back and try again. No, there's no point. You're kidding everybody if you think that's what's happening. So there is some difference there. And personally, I would say 1, because I think that the differences between techniques are not sufficient in my head to say you're going to make a big difference with one versus another. But having said that, I don't do any soft tissue because I do almost everything virtually, and it's way outside of my skill set. But so it might be that actually adapting the force or the amount or the location might change the outcome. So let's say you did 20 minutes or week 1, and they went, actually, that was really painful afterwards, but I might have got a little bit of benefit. Then next time I would go, actually, if you did 10 minutes and they got that bit of benefit, but they weren't significantly worse, that's an appropriate change. If that makes sense as a distinction. But in all honesty, at that second session, if you've changed something and it doesn't make any difference, it doesn't matter what you keep changing, it's not going to. I think we need to understand these conditions. We therapists are not having an impact on the underlying condition. With symptoms, maybe. Underlying condition, absolutely not. We're not making that better or worse.
But once they've been diagnosed and they're under treatment for the underlying condition or management, as you say, because there is no cure, then don't you think is there benefit for us to be able to manage one of the biggest symptoms, which is pain. Anything modulates pain, and we know that massage and hands-on can modulate pain in a positive way. Even if we modulate pain in a positive way only for a temporary time, that is a respite that we give those people, because I wonder some of the symptoms might be because of their kinesophobia, because of their fear. They know that they have this rheumatoid arthritis or any other condition, and they are fearful of moving because of that. So some of the symptoms might actually be due to that. So I wonder how, even if it is temporary, certainly it must be beneficial.
Yeah, I agree with you to a degree. So it depends what you're using as your outcome measure.
Yes.
So a different conversation if you're using kinesiophobia or some other measure. I think what we need to be careful of is if you're using pain, swelling, redness, heat as your outcome measure. So someone comes in, they go, I want my pain to go down, and you're providing some relief, but let's say it's lasting 48 hours. It's not sufficient in my eyes to keep seeking that treatment. So because it's not affecting the underlying process, and you have to think about so you might get 48 hours of improvement, right? But what's the cost to the patient for that 48 hours? And if they've got, let's take a patient who has unlimited resources, unlimited time, and they're keen to get that 48 hours of relief, fine. All bets are off, you go for that. But in patients who, they have to take time off work, or it's costing them money or something like that, 48 hours in these conditions is not sufficient. It's not, because they're going to have to come over and over and over again, and it's not going to change.
Correct, anything. Jack, but this is only true if you are using one intervention. So if you're judging the approach only by that one intervention, so if that 48 hours of pain-free, it's accompanied with the advice of gradual exposure, the advice of movement, the advice of do your meaningful activity, go back to your meaningful activities, that I think to me has great value. So we need to be careful not to become reductionist or just on the manual intervention. When we talk about intervention, we talk about a comprehensive approach.
I'm gonna jump in and very weirdly, I'm gonna side with Jack on this one. I mean, that literally never happens. But I think what you're speaking about, Anna, and this is my interpretation, and Jack, feel free to tell me I'm talking complete rubbish, but with our other, if we were talking about a truly musculoskeletal chronic pain condition, I would be 100% with you, Anna. My feeling is where Jack's coming from, and I don't mean to put words into your mouth, Jack, but is that we understand with a chronic pain condition that there is no, in inverted commas, injury, and that it is a sensitization of the tissues or a sensitization of the nervous system to experience pain. Whereas I think with something like rheumatology, because there is an underlying inflammation, there is an underlying issue, in a sense, what we're saying is there is an injury. That injury is continuing at all times, regardless of what we do. And so we may be able to multimodally improve or advise the client on improving their activity, on improving their mental health, on improving short-term pain relief. But actually, we're still at that point combating an active injury that is only continuing and doesn't have the same natural history as a true soft tissue injury.
For sure, but that's why you only approach management only when they've already been seen and they're already under. So we're talking about management, not treatment. So if the client says, actually the 48 hours allows me to be able to go for my walk or to be able to play with my grandchildren. And I put a great value on that, my 48 hours of pain-free and better movement. I think there is great value there.
Yeah, and I'm not saying there isn't great value in that. I think what you have to offset what are they gaining out of it versus what is the cost to them. And as with the greatest will in the world, with almost all of the audience are going to be in private practice, aren't they? And patients are going to have to pay for this. So there is that, and I used 48 hours as a real arbitrary a number, and I would suspect that with massage therapies, any physical therapies really, and even to a degree exercises, that actually you're going to be looking at way less than that. So I'd struggle to think of patients who I've seen in the past who have symptoms still, who are going to be even having benefit the next day after you've done it. So, and I used 48 hours because that's a good benchmark for a conversation about benefit versus reward. If it's the next day, then it's, and that's what I suspect a lot of patients are gonna have as a response. So the difficulty becomes in when, let's say you do your intervention, Anna, and then that allows the patient to then do some sort of rehab exercise program on top. That's a different argument as well. But then are they going to be able to do that or receive that enough times in a week, for example, for that rehab process to
that's what we need to that's what we need to be clear. Our intervention is not only massage. Our treatment is the encounter.
And in all honesty, I think if you had a rheumatology patient and you only provided them with massage, then they should not be in your clinic. And it's. But having said that, there are patients who are well off enough who, and I suspect some of you guys have them, who go, oh, I don't care what it costs. I like it. And this is where it's slightly different to the whole exercise. On the flip side, the whole exercise conversation, in that exercise takes a long time to actually create any difference, whereas with massage, it doesn't take any time, but then your extended difference out on longer term then is going to be much. And I apologize if I'm using massage as a proxy for soft tissue interventions. So whatever it is.
I just wanted to clarify that it's more than what we do with our hands. It's only one part of the intervention, which is reassurance, talking to the client, active listening, and rehabilitation advice. So,
and I think on the flip side of that, it's important to mention that it shouldn't be okay for people to use their hands as an excuse to have patients in the clinic to provide those interventions you just mentioned. So actually, a lot of these patients, where I'm trying to get to is, if your hands-on technique is not providing benefit over an extended period, then actually a soft tissue therapist is not where they need to be. There's going to be more appropriate therapists.
Correct.
However, having said that, there's a caveat that actually, if they've got a great rapport with you, then they're more likely to take on board the advice. So everybody's an individual. It's a very difficult conversation to really narrow down.
Agree.
And I think as long as therapists are not telling their patients or not assuming that they're creating any difference to the underlying process in either a positive or a negative, because you have to say that really, that if you're not creating a negative, you're not going to be creating, you can't create a positive either, because it works both ways. That they're not, if you said to someone, I'm going to do this, it will reduce the inflammation, that's incorrect, right? Yeah. As you said, Anna, it might reduce pain, it might reduce swelling, it might reduce heat even, but it won't reduce inflammation itself. And this is where we get into problems in more advanced clinics, is when patients think that that's actually happening, because we need them to understand that that's not the case. Because when you start to educate them about other things, if you're saying to them, this massage will reduce inflammation. And then on the flip side, you're saying this smoking will increase inflammation. Those two things butt up against each other. They don't, because there is no biological reason for massage to decrease inflammation. If anything, it would increase it, but it doesn't. So if it doesn't increase inflammation, there is absolutely no way it will decrease it. So I think that's a really important distinction for us to make here, as to what is actually happening at the tissue level. And was it you, Matt, I think, who texted me 6 months ago or something, and someone had said that they'd been told on a course that you push the inflammation around the body or something like that. That's the other thing I want to reassure people, is that's not happening. Yeah.
So I think it might be a good point, and I want to come back in a moment to discuss rehab versus management from an exercise perspective, from a clinic perspective. But I think it's probably a good point to just reiterate then. So what do you see as a contraindication as opposed to a red flag? Do you see that? So if we go back to your ankle example from earlier, then there was no reason why in that, particularly in that first presentation, there's no reason why you would be concerned about the use of, say, massage in and around the area if we would clinically reason that that's appropriate based on it being a sprained ankle. We're not going to make the rheumatoid arthritis any worse. And exactly as you sort of touch on there, there's nothing to the inflammation per se and the location of the inflammation that's going to be affected by massage. So what do you see as a contraindication to, let's use the proxy, massage when it comes to a rheumatology presentation?
The only contraindication really is that it's undiagnosed. And the reason for it being a contraindication is because and this would apply to me as well, is that we can't decide definitely what's causing the symptoms. So, unfortunately, there are times in rheumatology when you think that person's got rheumatoid arthritis. It turns out they have cancer, or they have some obscure fracture, or some other significant infection, for example, can happen, constitutional infections. And though that's where the contraindication lies, is treating those would be very, very bad, or attempting to treat those would be very, very bad. The real issue here is preventing them from getting care that they should get instead, or more effective care, I should say. So it really, if you've got a swollen, inflamed joint, and you are, for whatever reason, absolutely convinced it's rheumatoid arthritis and definitely not something else, technically you could treat that even though it's undiagnosed, because you're not going to make it worse. But the caveat to that is, I don't know, you don't know, as therapists, we don't know that isn't something else that's really problematic. And that's where you're going to get into hot water. So there's that really is the main distinction. But as we said earlier, the patient comes in to see you and they're undiagnosed. 6 weeks later, they might come back diagnosed with exactly the same symptoms. You can treat them at that point because they've been diagnosed. Symptoms are exactly the same. So this is where it gets really hard and really difficult, is there is, if you knew it was rheumatoid arthritis at week 1, crack on. But the trouble is you don't. And that's where the real difficulty arises. The only difference to that is in the spine, because of the affinity with these rheumatology conditions and osteoporosis. So again, let's remove our proxy for a second. Soft tissue massage, fine. Mobilizations of the joints, not fine.
That's what we wanted. That's very.
So and I don't use a distinction here between what would be a relatively gentle mobilization and a high volume manipulation. I don't, because I don't think you can draw a line between what is an appropriate force and what is an inappropriate force at that point. So as long as you are going soft tissue, that's absolutely fine. But anything that mobilizes the joints of the spine in a rheumatology patient, I would be really unhappy with that. Really unhappy with that.
That's good.
I think You make a really good point, Jack, about the
He does that.
Of,
have you noticed?
Yeah, I've said that quite a lot today. These are people at the end of the day, aren't they? And I think a lot of therapists, when we've spoken to therapists, see anybody with any rheumatological condition as contraindicated, which is a real shame, because actually these people still fall over and sprain their ankles. They still, have all the normal things that we see in clinic, and actually there's no necessarily any reason to treat them differently, as you say, if they're diagnosed and they're controlled in terms of their rheumatology. And also, they are sometimes people who just enjoy massage, and if that forms part of their overall well-being, as it might with any of us, then as long as we're aware of their condition and we are maybe careful around their flare-ups, then there's no reason really to see them as any different, as long as, like you say, we're not giving them this false narrative that we're going to move their inflammation away from their ankle or cure them or anything like that. So I think that's a really good thing for therapists to hear, that you're not going to do any damage to somebody just because they have an underlying rheumatological condition.
Exactly. And and again, that's an important distinction between what are you thinking you're achieving, what is the patient thinking you're achieving. If they're coming in because they like having a massage, carry on. What am I'm not going to bring up bloody Bannatynes, am I, and go, stop massaging rheumatology patients. It's ridiculous. So if they're coming in because they like having a massage, fine, as long as they're not believing that you are altering the underlying disease process, which, in all honesty, patients that I've ever met, they don't think that unless they're told. They sometimes you get some weird beliefs and understandings, and I would gently challenge those if someone says something bizarre. But I think it's more important that you're not sowing that seed, because, as we said, the absolute last thing you want to happen is someone goes, actually, I'm going to reduce my drugs because with the massage, I'll replace it with massage. And that is a shocking situation for us to get into. We absolutely don't want to be doing that.
And I know from the clients I have that have rheumatological conditions, there actually tend to be a population who are very well informed about their condition. When they've had, obviously, their diagnosis, they're extremely well informed about their condition, and actually just put together their own kind of general way of looking after themselves and managing, and maybe they want massage to be part of that, just because it is a pleasant experience for them when they might suffer some pain in their day-to-day life.
Okay, then. So I think probably a third time lucky, I'm going to pick up on this rehab versus management thing within the clinic, and touch on OA, I suppose, in that capacity. As I mentioned earlier, for me, if someone comes in and they've been diagnosed with OA, I see that as an opportunity to help rehabilitate them. That might not be return them to their joint to original, but certainly we can get a huge amount of function back again through the kind of strengthening work, perhaps assisted by some pain relief through massage, etc. But that's specific for OA, and like I said before, I didn't realize OA actually came under the rheumatology banner. So for other conditions such as rheumatoid arthritis, is there a place for rehab, or is it actually just a management program?
Oh, absolutely, 100% place for rehab, and there's a lot of reasons for that, which we probably don't have time to go into today. But there's loads that can be done to improve function through all of those interventions that you just mentioned, with regards to increasing range of motion, strength, cardiovascular fitness, general health, all of those things. So I actually wouldn't, in these patients, separate out management versus rehab. I think to take Anna's point from earlier, you might be doing a management strategy which allows them to rehab, in inverted commas, but also their rehab will manage their symptoms in the longer term. So exercise, for example, there are very few situations where an exercise would improve their symptoms in the relatively short term, but with regards to the long term, then being active, let's go there with that, is far better than being inactive. So I would merge them together, and I would try to set out a strategy that is both short, medium, and long term. So that probably fits into what Anna was saying with, okay, short term, we can do this, which will help you do that in the medium term, which will enable us in the long term to achieve these goals.
Perfect. That's brilliant. So then what we love to do, and as our producer, hopefully you've listened to our podcast and you notice this, but we really like to introduce a theory to practice element to the podcast, so that when people are back in clinic, they've got something that they can apply immediately. So what would be, I suppose, your takeaways or your theory to practice that you'd really like to, from your position, communicate out to sort of manual therapists of all flavors?
I think the first thing that I would suggest is that people understand what messages they're giving to the patient, to the rheumatology patient, when they do things. So I assume that everybody explains what they're doing and why they're doing it, and how is that going to be interpreted by the patient. I doubt there's very many situations where the patient comes in, lies down, and you just start doing whatever you're doing.
It's not common. No.
Not common. Maybe if they've attended for the 50th time or something, that might be the case. But so. And one of the ways that you can do this is, and I forget who coined the idea, it might be Kieran O'Sullivan, but I forget, is to say to the patient, would you explain back to me what I've just told you? And I'm not going to lie, it will take you 1 or 2 attempts at that, and you will be amazed at what people parrot back at you that they've heard. And as soon as that happens, and someone says something back to you that you go, that's not what I meant, then you know you've got to change that language, because it will be ingrained in that person so quickly. And especially if you then do something that then helps, that's almost worse, because they're then thinking this spurious reason for what you've done is actually beneficial. That's going to affect their whole outlook on the situation. So definitely that, if I would suggest anything. The other thing I would suggest is to attend the course that you guys are running, which is what with me about rheumatology, and we can go into all of this in a lot more depth and ask questions and stuff. And I might occupy a niche, but I'm very good at shameless plugging.
I can see another podcast coming up with him as well, isn't it? Series 2, Jack March, Series 2.
Well, see, what I love about that is, so for you guys listening, what you can't see is the range of nodding dogs that are just going on whilst Jack was giving our theory to practice there, and I think probably some insight from that is, you mentioned, Jack, that a huge amount of the work that you do at the moment is online. And so as much as anything, the language you use has to be bang on, because there is a limitation to the amount of sort of body language that can be interpreted, and that adds to the total understanding from the client. But if the only thing you're providing them is language, then that language has to be bang on, and checking that they're understanding it is really important. And we know, I'm really pleased you pulled up on that point, that, we can say one thing, we might do something, and the client may then interpret those two together in a third sort of scenario, and we've got to be really clear about that. So no, that's superb. Thank you very much. So I think probably then, just conscious of time today, we're going to look at wrapping up. So, I mean, shameless plug notwithstanding, what's next for Jack March?
Well, on the horizon at the moment is Therapy Life Pelvic Health. That is occupying all of my brain space currently. But I'm trying, as we said at the beginning, I've been leaning into advanced practice more, and I want to try to move away from that to a degree, because I am admitting a huge population of therapists. So I want to work with you guys on the course that we just mentioned. And apologies if you hear my cat strangling.
That's a cat. I thought it was a child.
Yes.
Yeah, people. And I'm trying to run some introduction to rheumatology sort of sessions as well. And all of these are on my website. You can find those, rheumatology.physio, to try and get a bit more entry level stuff, so that people who aren't working in advanced practice roles or that kind of thing can have access as well. But there's loads of free stuff on my website as well. So if people want to get involved, it is aimed at physiotherapists, because I am a physiotherapist and it's easy for me to do that. But there's quite a few things on there which would be really useful for massage therapists and stuff as well, to understand the conditions better if that's something they want to do.
Absolutely. I think speaking from a lot of the audience that we interact with fairly regularly, I think they'll find a lot of those resources actually very useful, if only to refer back to whenever they're just refreshing their memories when they know they've got a client coming in and a suspected RA or a diagnosed RA, for example. So no, so that's brilliant. So yes, so let's go on. Let's go back to this course. So 28th of April. Under our other hats of the school, we have managed to nab Jack for 3 hours of his time in our CPD snacks, and the tickets are up on Eventbrite at the moment. We'll make sure links to those are available wherever you're listening to this. And Jack will be going into more detail. He'll have a little bit more time with this, which will be fantastic. And again, it's aimed specifically at soft tissue therapists, massage therapists, manual therapists, and how to, well, I suppose a little bit more on how to recognize these conditions, particularly if you spend a whole day teaching advanced practitioners how to do this. So that is absolutely fantastic. Thank you very, very much for joining us today.
No worries, an absolute pleasure, and I'll happily have another argument with Anna Maria at any point that she wants to have one.
An argument, obviously, doesn't know what an argument with me is.
No, that was ace. Really, really enjoyable. Hopefully, really, really helpful. So that's rheumatology.physio if you want to go and find out a little bit more about Jack and look at the resources he provides. 28th of April if you want to come and listen to him natter on with us at theschool.co.uk. And Pelvic Health Live. I would get shot by my producer, who is actually looking at me right now, if I didn't mention Pelvic Health Live. And Jack is presenting on
axial spondyloarthritis in women specifically. Yeah.
See, I'm so glad you said it. Yeah, so that's absolutely superb. And that is on the 6th of March.
Correct, and it's free. Yeah, so
and it's free. Yeah,
got a ticket. Why on earth not?
Yeah, so tickets are available. They're available for free, like all of the Therapy Live events, free on the day, a whole bunch of stuff. We will be there as a massage collective discussing manual therapies around pre and post pregnant, pre and pro pregnancy? No, prenatal and postnatal. And I will be discussing separately manual therapies involved in pelvic health directly, so outside of the scope of pregnancy. So it's going to be really, really fantastic. Anyway, we will stop wittering on for now, and we will bid you adieu.
No worries, pleasure.
So that just about wraps things up again for us today. So thank you very, very much for joining us. I hope you found that helpful. I certainly did. Rheumatology is definitely not one of those areas I would ever proclaim to be any kind of expert in. So that was really helpful for me. As always, you can reach out to us with any questions, suggestions or feedback. We're at massage@physio-matters.com, or you can find us as the Massage Collective on the usual social media channels. If you found this particularly helpful, it would be really great for us if you could perhaps leave a little review on your podcasting platform, or share this amongst other therapists you know who are likely to find it useful, who might not have come across a podcast yet. It really helps us to get the message out there, particularly around bringing evidence-informed practice into the clinic for better outcomes with our clients. And so until our next episode, which is likely to be the live recording from our Therapy Live Pelvic Health review of massage and manual therapies pre and post pregnancy, look after yourselves and we'll see you very, very soon.